PSA followed by an MRI, followed by bone scans or PSMA scans, and then a targeted prostate biopsy. So these are ways now which have changed the traditional way that we diagnose prostate cancer. So with the MRI, we have T2 weighted images that show us the gland and show us where the cancers are possibly in the gland. Then we can use diffusion weighted images that show us more carefully and more succinctly where the cancers are. In this case, this dark area here. We can use perfusion weighted images where we inject dye and show that the cancers take up the dye and are vascular. We can use spectroscopy, which we don't do that much anymore. We can see the chemical signatures of cancer in the gland. We can use PSMA PET scan with MRI now incorporated into MRI to help us get the best idea where the prostate cancer is, if it's in the prostate, outside the prostate, and so on. We can initiate a very careful targeted biopsy of the areas that are abnormal in the prostate. We can then now treat either part of the gland with ultrasound or the entire gland with ultrasound under MRI guidance. And so these are all the exciting things we can do now that we weren't able to do just a few years ago. And so here's a 65-year-old man with an elevated PSA and a prior negative biopsy. So he underwent an MRI instead of a repeat biopsy. So here you can see that on the T2 weighted images, there's a dark spot here, which is bright on the diffusion weighted images, dark on the ADC images, and has a very vascular curve on MRI. And this tells us this is most likely a cancer and probably a higher grade cancer. So we give it a PIRAD score of 5. And PIRAD scores of 5 mean that it's high likelihood of a cancer and higher likelihood of a higher grade cancer. So we can also use MRI with PET scans, and the PSMA PET scan is a real advance in those situations where MRI may be negative. The MRI also not perfect. It picks up about 80% of all the high value targets in the prostate, and the combination of MRI and PSMA PET really pick up close to 90% of all significant prostate cancers. So once we pick it up, we have a variety of ways we can use to target it in a very smart fashion, and this is one of them. This is a MR-guided system which allows you to line the MRI this way with a transrectal or transgluteal or transperineal way to biopsy the prostate. We can also do ultrasound fusion with a variety of different systems to also get this target. But in my world, I prefer the MRI system because I know every time that I can see the target under MRI, I can biopsy that target under MRI. And we do this biopsy in a variety of different ways, and this is one schematic that looks where we put this biopsy guide into the rectum, we hook up the machine, and then after taking some MRIs, we then take the biopsy here of the high value target. And here's what we do. So under MRI guidance, we see the target here, we aim our device to the target. We can do this through the rectum, we can do this through the perineum or the buttock muscles. Then we align it in 2 different planes, and here it is right there. And then fire the needle and take only precisely that target. And this was a pathology Gleason 3+4. And that's the high value target. The first biopsy was negative. Remember that if they did another biopsy the same way, they'd be probably negative, and the third biopsy would probably be negative. But this way, we know exactly where to go and get the most high value target. And that's the other way to look at it. That brings us to treatment. And treatment now has been revolutionized by 2 new FDA approved devices in 2021. The first we'll discuss is the Profound TULSA system. And this little video will show you how we use MRI to diagnose the cancer. And now in the MRI scanner, we can treat the cancer very precisely with ultrasound waves, sound waves, at a specific frequency. We put a little catheter into the prostate after the patient is anesthetized. We take MRI scans and then use the device centrally to heat the prostate very precisely inside where the cancer is and leave the outside spared where the nerves are. And that's what causes the problems with impotence and incontinence. And we avoid those areas very precisely. And the other thing I like about the system is that we can measure how hot it gets in the very center or at our target, and also at the periphery where the nerves are. So we know not to heat the nerves, we know not to heat the urethra, the bladder, neck, or the sphincter. Those are very critical structures, and this is for the first time a way to do that. And this is how one of our first cases was done a few years ago with Dr. Pantuck here. Here's the actual device going into a patient over a wire. The patient's in the MRI scanner, and then here's the actual treatment where we run the device after adjusting everything and basically start treating in this manner the entire prostate gland or part of the prostate gland, depending on how much cancer and where the cancer is within the prostate. And this is what it looks like after we're done. So we don't stop at the treatment. We follow our patients throughout their lives. And here is the initial gland on the T2 weighted MRI with the cancer back here, 58 cc gland with a PSA of 5.5. The PSA was elevated. We did a targeted biopsy, found Gleason 3+4 cancer. Then we did the treatment, and right immediately you can see after the treatment, the whole gland goes dark, and then keeps being dark 1 month later, 3 months later, and 12 months later. And most importantly, the whole gland kind of shrivels up, as you see nicely. The center of the gland where the urethra is spared. It's spared here and it's spared there. And this man had no urinary problems and almost no erectile dysfunction. So this was a very nice treatment of the entire gland, and he's still cancer-free now 3 years after his treatment. So this device was on the cover of the Journal of Urology in 2021 in this seminal article which we published. And that's what I want to do, is make sure that everything we do is carefully researched, and because I don't want to do anything that isn't in the patient's best interest. And this showed some of the best results for this device that has ever been shown for any prostate treatment. So here, the PSA went down to 0.34 on average and stayed down to 0.63 at 2 years. And 80% of men had no cancer at 1 year after their treatment. And by 2 years, only 7% of men underwent a second treatment for any sort of residual cancer or new cancer that appeared in the prostate. And we have learned from the study that we need to be careful about not screening without the CT scan and other things. So now we use CT scans to make sure there are no calcifications and other things, so that we can even achieve higher results and better results for men, better than 80%. And that's hopefully what the new studies will show. Also, when we looked at safety, the procedure was very well tolerated. There were no intraoperative complications. Some adverse events, including some infections, a little bit of urinary retention, some stenoses, and other things that resolved with over time. There were no severe urinary incontinence symptoms. Only 2% had some moderate urinary incontinence, and 20% of men had some moderate erectile dysfunction, but most of them, 83% of them, went back to their baseline by 6 months.